Medieval doctors literally sniffed their patients' urine to make life or death decisions. This practice, called uroscopy, put the senses at the center of diagnosis. Sight first, then smell is a quick, powerful clue. First, we'll show you step by step how it worked, what smells they listened for, and why those old instincts still echo in modern lab tests. First, a sample was caught in a clear flask called a metulla. Physicians held it up to the light and noted color and cloudiness. Then came the sniff. They gently lifted the flask and inhaled, comparing what they smelled to medical guides. A sweet, honey-like odor often pointed to what we now call diabetes. Medieval doctors sometimes even tasted urine to confirm that sweetness. A sharp, sour smell could suggest problems with digestion or metabolic imbalance. Putrid or rank odors signaled infection or gangrene. A fishy or ammonia-like smell hinted at urinary infections. Chronic, musty scents were read as signs of long-term illness. To sharpen their verdicts, some practitioners warmed the sample to release odor or matched smells against illustrated urine wheels and texts by authorities like Avicenna. Smell alone wasn't the whole story, but it provided immediate, actionable information in an age without chemical tests. Today we replace those nostrils with reagent strips, cultures, and instruments that measure specific chemicals, far more precise, but born from the same instinct. Urine gives clues about the body. Stay tuned to learn the real smells, the surprising cases that convinced doctors to trust their noses, and what those scents meant for treatment in medieval medicine. Why doctors studied urine to diagnose disease. Medieval doctors paid close attention to urine because it carried chemical traces the body was trying to get rid of, and scent is one of the quickest ways to notice those traces. Uroscopy, the practice of examining urine, was done step by step. The patient provided a fresh sample. The physician looked at its color and clarity, and then leaned in to smell it. Smell was treated as a direct clue to internal processes. Different odors pointed to different problems in a simple, sensory way that anyone could learn to recognize. First, the doctor would make sure the sample was fresh and in a clear container so odor and appearance were not distorted. Next came the sniff. Doctors would waft the smell toward their nose rather than inhale deeply, and mentally compare what they smelled to familiar references: honey, rotten meat, fermenting fruit, or a musty, mousy scent. A honey or sweet-smelling urine was interpreted as containing excess sugar. In later medical language, this quality became linked to the term mellitus, meaning honey sweet. A sharp, fruity, or acetone-like scent suggested that the body was producing unusual breakdown products, a sign of a severe metabolic problem. A foul, putrid, or ammonia-like smell led physicians to suspect infection or decay in the urinary tract. Real diagnostic methods combined these smell clues with other sensory checks. Physicians kept written lists of odor descriptions and trained apprentices to match smells to conditions. They compared the detected scent with the patient's symptoms: thirst, fever, pain, and with what the urine looked like. In some cases, they also tasted urine to confirm sweetness, though smelling was safer and more widely used. Doctors understood that diet, overnight fermentation, and storage could change odors, so they emphasized smelling fresh samples and noting the strength and character of the scent rather than relying on a single whiff. Smelling urine had obvious limits, which physicians often acknowledged even then. Odor is subjective. Two people can describe the same smell differently. External factors such as foods, medicines, or how long the sample sat out could confuse the picture. Today's laboratory tests address those limits by measuring specific substances directly. Dipsticks detect glucose and ketones, cultures grow bacteria to identify infections, and instruments can analyze volatile compounds precisely. Modern methods are more sensitive and objective, but they follow the same basic idea medieval practitioners used. Urine holds chemical signals that reflect health, and smell was the earliest, fastest way to read some of those signals. In short, scent-based examination offered medieval doctors an immediate, low-cost tool for spotting major problems. It could point them to sugar in the urine, fermentation or ketone production, and signs of infection, clues that often prompted more careful treatment. Despite its subjectivity, smelling urine was an important and practical diagnostic step because it provided quick, actionable insight when no laboratory testing was available. Why smell was considered a medical tool. Physicians relied on smell because it gave fast, usable information when no instruments existed. A patient would bring a sample in a rounded glass called a metulla. The doctor would first hold the flask away from the face and then draw the scent toward the nose, noting anything that stood out. Smell came after a quick look at color, but before any further tests, because odors evaporate and reveal volatile chemicals that the eye cannot detect. They listened for specific smells and tied each one to likely problems. A sweet or honeyed odor suggested excessive sugar in the urine, a clue that a person's body was not handling sugar properly. Doctors treated that finding differently than, say, a simple fever. A fruity or acetone-like scent hinted at an emergency metabolic state when the body breaks down fat instead of sugar. Such a smell was alarming and often prompted stronger remedies. A sharp ammonia or putrid smell usually pointed to infection or urine left to sit too long, and a very strong, concentrated smell indicated dehydration. Fermenting or yeasty notes could suggest bladder fermentation or overgrowth of microbes. These associations were practical. Smell helped decide whether to focus on diet, cleansing, or stronger interventions. The practical technique mattered. Doctors often warmed the urine slightly or held the mouth of the metulla near a flame to encourage volatile molecules to rise, then sniffed the vapors gently rather than plunging their nose into the fluid. They compared odors to familiar things: honey, rotten meat, acetone, so their descriptions made sense to patients and apprentices. Some physicians trained their memory of smells and kept mental lists of typical scents and what those scents usually meant for treatment choices. That method is why smell could shift a diagnosis immediately, even though it depended on a physician's experience and sense of smell. Smell-based diagnosis had clear limits. However, it was subjective and could be influenced by diet, storage, or the container itself. Modern medicine still values the same clues but confirms them with precise tests. Dipstick strips detect sugar and infection markers. Chemical assays measure ketones, and cultures identify bacteria. Scientists now even study tiny chemicals that evaporate from urine with machines, a high-tech echo of old sniffing, to look for disease signatures. In short, smelling urine in the medieval clinic was a practical, immediate tool that guided choices. It offered useful hints, but lacked the objectivity and specificity of laboratory tests used today. Did urine diagnosis actually work? Medieval physicians placed great weight on the smell of urine because certain odors do correlate with real biological processes. They used a glass flask called a metulla to collect a sample, then lifted it to the light to look and to the nose to sniff. First, they would uncork or tilt the flask slightly and inhale carefully, noting whether the urine smelled sweet, sour, putrid, ammoniacal, or faintly floral. Each scent had a name and a presumed meaning in medical textbooks of the time. Sweet-smelling urine, for example, was interpreted as the presence of a sugary substance, which later gave the condition its name, diabetes mellitus. Mellitus meaning honey-sweet. The step-by-step practice of uroscopy kept the sense of smell at the center. Physicians would inspect appearance first, then draw near the mouth of the metulla and inhale. Some tried smelling different layers of the sample because concentrates of volatile substances could settle. They compared odors to familiar references: honey, rotten meat, ammonia, or mustiness, and matched those impressions to lists of symptoms and prognosis. Real diagnostic methods included careful comparison against texts, consultation with colleagues, and repeated smelling over time to see if the odor changed with treatment or diet. Smell was treated as one sensory measurement among several, but it was an important one because certain volatile compounds in urine can be unmistakable. In practical terms, smell-based diagnosis did sometimes work. Ketone bodies produced in uncontrolled diabetes create a fruity or acetone-like odor that can be detected by smell, and infections with bacteria, such as proteus, can produce a strong ammonia or foul odor when bacteria break down urea. Metabolic disorders, too, can give characteristic smells. Maple syrup urine disease yields a sweet, burnt sugar scent, and phenylketonuria can cause a musty smell. Even diet and drugs leave aromatic traces. Asparagus makes urine smell sulfurous, and garlic or certain medications can add pungent notes. So experienced observers could sometimes separate dietary causes from pathological ones. Despite these successes, smell alone had clear limits. Odor cannot quantify how much sugar or bacteria are present, and many conditions produce no distinctive scent at all. Contamination, storage, and a patient's recent meals often masked or mimicked disease-related aromas, and different observers describe the same smell in varied ways. Modern laboratory tests are far more precise. Dipsticks detect glucose and ketones, cultures identify bacteria, and instruments like gas chromatography, mass spectrometry can profile volatile organic compounds with expert accuracy. Research even explores electronic noses that imitate the human ability to sniff out disease, showing that scent can be a useful pointer when combined with reliable measurements. In short, smelling urine gave medieval doctors valuable clues on occasion, but it was a blunt tool whose findings had to be checked and interpreted carefully. Medieval uroscopy put the nose to work. A doctor would ask for a fresh sample in a small rounded flask called a metulla, let it settle and warm a little, then uncork and sniff carefully, sometimes again after a gentle swirl to release different volatile smells. Different odors were read as clues. A sweet or honeyed scent suggested excess sugar, what we now call diabetes. A fruity, acetone-like smell pointed to more severe sugar problems. A foul, ammoniac, or putrid odor often signaled infection. A sulfurous or rotten egg smell could hint at liver or bile issues. Physicians recorded these associations on charts or the popular uroscopy wheel and combined the scent with what they saw in the patient's story. Smell could be revealing, but it was easily affected by diet, medicines, or dirty containers, so medieval practitioners treated it as one piece of evidence, not a definitive test. Today we still recognize some of the same scent clues, for example, the fruity smell of diabetic ketoacidosis. But modern medicine uses urine dipsticks, microscopes, cultures, and chemical analysis to identify causes far more reliably. To summarize, medieval doctors used the metulla and a practiced nose to gather clues. Specific odors suggested particular problems. Smell was helpful but fallible. Modern labs now confirm and quantify those signals. If this little history surprised you, subscribe and leave a comment. Next time we'll explore another strange-sounding medieval diagnostic method and show how it led to today's tests.